Welcome to part 6 of our GI system PowerPoints, and this is on enteral feedings. Sometimes our patients cannot take in any nutrition by mouth. This could be because they physically cannot swallow, it could be too risky to swallow, they can't take in enough by mouth, or they're too sick to swallow, like being on a ventilator in the ICU. In these instances, we still need to get our patients nutrition. The body must have calories and protein to maintain life, and if they're sick, they need those calories and protein to heal. The best way to get nutrition to the body is by the gut, using the body's natural digestive system to get the calories. But if the patient can't swallow, what can we do? Well, we have ways to bypass the mouth and swallowing reflex to get food in the stomach. We do this by either placing a tube down the nose into the stomach or by surgically placing a tube into the abdomen into the stomach. There are pros and cons to both methods, but for block 1, we're only going to focus on the surgically placed tube into the abdomen. You'll learn about the other tubes in a later block. These surgically placed abdominal feeding tubes are called PEG tubes or percutaneous endoscopic gastrostomy tubes. They go through the abdominal wall directly into the stomach. These are used for long-term nutritional support, so they're very common in long-term care and in the ICU for patients who've been critically ill for a while. If the patient doesn't have a stomach or has significant stomach issues or are at major risk for aspiration, they can actually place the tube into the jejunum. They work exactly the same way, but they do have some differences. The first picture shows what a PEG looks like. It's going externally through the skin, through the subcutaneous fat, through the muscle, through the stomach wall. It has a little balloon or some sort of bumper that's going to keep it in place in the stomach. The second picture is what it looks like externally. And the third picture is of where the end of the tube would sit if it were placed into the jejunum. These tubes are really easy to care for. We want to make sure that the insertion site stays clean and infection-free, and we want to make sure that the tube doesn't clog. I said caring for these tubes was easy, and it is, but there's a lot we need to manage when it comes to tube feeding. First is the actual feeding itself. The patient will be prescribed a formula of liquid nutrition by the registered dietitian. The RD takes many things into account when they choose what formula to choose: comorbidities, lab values, nutritional demands, allergies, and how sick the patient is. The RD will tell us how often the patient needs the formula, whether it's bolus feeding, intermittent, or continuous. Bolus feeding is like us eating a meal. It's a large amount of formula in a short period of time. Intermittent feeding is when we give the feeding at regular intervals using a bag or a pump. Continuous feedings are when we use a pump to continuously deliver formula all day long. Regardless of how it's to be given, the RD will tell us how much and over how long of a period of time. If we're giving continuous feedings, the RD will order it to be started at a very slow rate and to increase the rate over a specific period of time if the patient tolerates the formula. When we're watching for tolerance, we're making sure the patient isn't having nausea or vomiting, they aren't having diarrhea or constipation, their abdomen isn't distending, and we're measuring gastric residual volume. Checking residual volume has been questionable practice in recent years. There's evidence suggesting that checking residual is only beneficial during starting and increasing the formula amount and is not needed once tolerance has been established. This is something you'll need to follow your facility's policies and procedures on. If your facility says to check residual, do it. Residual is the amount of formula left in the stomach at any given point. The thought used to be that if there is formula left in the stomach, the patient isn't digesting it, and therefore they're not tolerating it, but recent evidence-based practice has shown that residual is not an accurate reflection of digestion. Monitoring the other aspects of tolerance like nausea and vomiting and distension are more accurate indicators of tolerance. Evidence did show that continuous feedings had the best tolerance compared to bolus or intermittent, so you'll see that used more oftenly than the other types of feedings, especially in acute care. In addition to the feeding and monitoring tolerance, we need to make sure that we're providing comfort measures to our patient. They may have a very dry mouth if they're completely NPO, so we need to provide frequent oral care, including brushing their teeth and offering ice chips if they're allowed to by the provider. Some disorders cannot have ice chips at all. We also need to make sure our patients are being repositioned and their skin is being monitored. Lack of nutrition, especially albumin, which is protein, is a major risk factor for skin breakdown, so any patient on enteral feedings is at high risk of developing skin breakdown. We also need to make sure we're doing good abdominal assessments to make sure the patient is tolerating the feedings. We also have to make sure we're flushing the PEG tube to make sure it doesn't clog. If we're giving medications through the PEG, we typically flush with water before the medication, dissolve the medication in water so it doesn't have chunks, and then we flush it with water after we give the medication to make sure that tube is clear. Sometimes the RD will order free water flushes, which is like you or I drinking a glass of water, but it's going to go through the PEG tube. This helps keep the tube clear and provides hydration. We also need to make sure the head of the bed is elevated at all times to help prevent aspiration, which is when gastric contents come up the esophagus and go down into the lungs. If your patient is awake, we need to make sure that we educate them, and we educate them on everything we're doing, as these tubes are long-term and they will either go home with it or they'll move to another facility with it. The tube will need to be cared for. They need to know about the nutrition, they need to know about cleaning the site, any symptoms of complications, and they need to know how to administer medications through the tube and how to prevent complications. Enteral feedings are not without risk. The first complication you could see is infection. The tube goes through the skin, fat, muscle, and stomach wall. That leaves a big hole where bacteria can enter into the skin and cause infection. Also, stomach acid could leave the stomach and seep through the skin, digesting everything in its path. We have to check and clean the insertion site, usually once or twice a shift if it's a new PEG, and daily once it's established, once it's healed. Also depends on your facility's policy. We're assessing for drainage, redness, tenderness, which are all signs of possible infection. The tube may become clogged, especially if we do not flush the tube well enough after we give medications. Your policy will dictate how you will attempt to unclog it, but we never want to push with all our strength. The tube can rupture inside the patient, and then we have an emergency situation. The best treatment for a clogged tube is prevention. The tube can also become dislodged out of the skin if it gets pulled on. We need to make sure that there's enough slack on the tubing so it can't get pulled, and we need to make sure that a confused patient doesn't pull at the tube. If it does get dislodged, it could require another procedure to put it back in. We also want to make sure that we're assessing our patient for malnutrition with the help of the RD. The RD will monitor the labs, but we monitor the eyes and nose, the vital signs, and the physical assessment. We also want to assess for signs that the patient may not be tolerating the feeding, especially vomiting. If the patient does vomit, then they're at risk for aspiration, which we're going to discuss more about on the next slide. Out of all these, which do you think is going to kill the person the first? If you guessed correctly, then you figured out that aspiration is going to be what kills our patient first. Aspiration is deadly because it's not only the formula that's going into the lungs, it's the gastric acids as well. Those acids digest lung tissue very quickly, and these people will develop aspiration pneumonia, which stops oxygenation from occurring in the damaged parts of the lungs, and these patients usually end up ventilated in the ICU and may die. So what symptoms do we want to look for when it comes to aspiration? Well, anyone who's nauseous or vomiting while on tube feeding should get our priority, and we must assess them right away. We can see choking or coughing. We might notice decreased oxygenation levels, and if we auscultate their lungs, we may hear rhonchi or crackles. The issue is not every person coughs and chokes. Some people will silently aspirate, especially if they're laying down. That means we must be assessing lung sounds and vital signs frequently on our tube feeding patients. I don't mean every hour, but maybe every 4 hours we're doing it. Just want to go in there, check their pulse ox, listen to their lungs really quickly, and make sure that they're okay. So what do we want to do if our patient is aspirating? Well, the first thing we want to do is stop the tube feedings and then go check on your patient. Check their oxygen levels and listen to their lung sounds. If your policy allows it, check the residual. Then call your provider. If the patient's doing poorly and your facility has this, you can call a rapid response. Rapid response teams are a special group of healthcare providers who come to pre-emergent situations to resolve the situation before it turns into a CPR type of situation. The best way to treat aspiration is to prevent it. We elevate the head of the bed, we do frequent assessments for tolerance, and we follow the orders for rates and volume of administration. Once aspiration does occur, treatment really becomes controlling the damage, preventing pneumonia, and supporting oxygenation. And this is the end of GI.